Well, thank you so much for that kind introduction. And thank you all for having me here. I know want to stay on time, so I'm going to keep moving because I don't want to go over. I'm going to speak today on GAT. These are my financial disclosures, none of which I think are pertinent to today. I'm going to start off with just a brief overview of my surgical algorithm, then introduce GAT, show some basic videos, show some of the instruments that I use, and then kind of wrap it up and talk about future implications. I think anybody that cares for glaucoma understands that the standard of care is not perfect, and although trabeculectomies have saved millions of people from going blind, they still have their faults. And the same thing is true with tube shunts, which you guys now are getting more and more experience with in India, thankfully. I basically tell my patients that I'm a fancy plumber, and what I'm going to speak about today is really opening up a patient's outflow system. They must have an intact outflow system, and I'm going to specifically speak on GAT. And what we're talking about broadly is trabeculotomy. And let's talk a little bit about what a trabeculotomy is. And it's not a new surgery. It's been done, back in the 60s by Redmond Smith, one of the great thinkers in the field of ophthalmology. And I love this image down here showing that trabecular shelf opening up. And he was able to describe that in the 60s. And we now have fancier technology showing the same thing he described much long ago. Now, Morton Grant, thinking of another great leader of our field, one of the landmark articles in the 50s, he showed that the vast majority of resistance to outflow is in glaucoma, in primary open-angle glaucoma, is the trabecular meshwork. And we know quite well with a lot of studies that trabeculotomy is probably without question the standard of care in children. We actually, if you look at the 5-year outcomes for ab externo trabeculotomy in POAG and pseudoexfoliation, these aren't much different than the TVT trials, quite significantly high success rates. And when you look at trabeculotomy for the treatment of steroid-induced glaucoma, you see it actually is shown to be more successful than trabeculectomy. And this study shows that the more of the angle you open up, the greater the success rate is. But what's the problem with the traditional ab externo trabeculotomy? Requires a lot of time, conjunctival incisions, and it may preclude further success of other incisional glaucoma surgeries. We're talking about really an evolution of trabeculotomy that we're witnessing in this day and age. And what I want to introduce to everybody is something called GAT, which is an ab interno suture trabeculotomy, making 360-degree circumferential trabeculotomy through 2 small paracenteses with a 5-0 proline suture. Now here's a video, and for those that are skilled or learning angle surgery, I'll show you some goods and some bads of this video. You can see right here, I hit a couple limbal vessels. That's a big no-no, and you'll see why later. I inject some Myocol, then some Helon GV. These are just, I'm sitting temporal. This is a 5-0 proline that I've blunted already, and I'll show you a video of that blunting later. You can see this blood right here creeping in between the interface of the gonioprism and the cornea, which is going to start to obscure the view. With an MVR blade, I make a goniotomy. You can see the blood is coming right there and obscuring the view just a little bit. But I'm making a goniotomy and I'm pushing down, and you're seeing the white strip of the back wall of Schlemm's canal. Now, this is key. When you're going in, you want to go as tangential as possible to the back wall. You don't want to go perpendicular or even get close to going through the back wall. As parallel as possible, as tangential as possible. And you want to see it almost turn the corner, the first 90 degrees. That's when you start to feel the resistance, and it's going to start going around. You want to feel that resistance. If you're just going like this, you don't feel the resistance, it's likely broken out or it's in the suprachoroidal space. The most likely point of going in the suprachoroidal space is that first 90 degrees. You can see the resistance increasing, and then thankfully, you'll see that tip having come around 360 degrees. And then you reach over it gently and carefully, retrieve the distal blunted end of that proline, and then I hold it still. And then with my other hand, I will then pull on the outer portion of the suture. Thus, you have a 360-degree ab internal trabeculotomy in a matter of minutes for a matter of a few dollars. Now, this is what I like to do is I will estimate the outer circumference of Schlemm's canal. It doesn't have to be exact, but basically, and I'll kink that suture. So if you're passing it and you don't see it, and then you see that little bend, you know you've gone too far. You know you're in the wrong place. That's a great tip for early on. And then this is what it looks like to blunt that tip. This is a low temp cautery. The minute you start to see it change, the most subtle change, the smallest tip is what you want to make. Well, it looks all great and fun and cool, but does it actually work? And so we published our initial results down in 2014, showing a significant effect and benefit in primary open-angle glaucoma, and more so in secondary open-angle glaucoma, with a significant decrease in pressure and medication dependence. That's true also with congenital glaucoma, which, as we talked about, my opinion is that trabeculotomy is the gold standard for primary congenital glaucoma and juvenile open-angle glaucoma. Now, we reported our two-year data as well, and I'm going to briefly go through this because it's something you can just read in the article. But the key thing, this is looking at the different groups: POAG, phaco-POAG, pseudophakic POAG, secondary, phaco-secondary, and pseudophakic secondary. Whenever you look at any of these MIGS trials, look at who we're doing this in. This isn't the eye stent data. This is real disease, real glaucoma, pressures in the 30s to high 20s on 2 to 3 medications with significant visual field loss. And what we see across the board after 2 years, you see a sustained drop in pressure from the 20s to 30s down to the low to mid-teens, and a sustained drop in medication from 2 to 3 down to about 1 and a little bit. And we talked a little bit about the complications. The most common complication is hyphema, usually about a third at 1 week, and that goes away pretty quickly. Other than that, no significant complications. Now, although this was developed by our practice, and I was the first one in the world to do it, it's now been performed in several countries. And actually, what's nice to see is it's been published on in a peer-reviewed fashion in over 20 articles by various groups around the world, which is what you always want to see. It's one thing to say, hey, I can do this, but can this be replicated around the world with similar effect? And these studies show without question it can be. So in conclusion, GAT is a novel, safe, minimally invasive conjunctival sparing surgery. The 2-year data shows that there's a mean drop across the board from 26 to about 14 millimeters of mercury in pressure, and from 3.1 to 1.4 as far as medication is concerned. We need to start thinking about cost-effective delivery of healthcare, especially when it comes to MIGS. We had a discussion earlier about MIGS in India, and this has tremendous implications, in my opinion, with India, because it can be done in a very inexpensive way. I'm collaborating with my partners down at Arvind and Pondicherry, and we're hoping to be reporting on our 1-year data. Whenever I've come to India and performed GAT, I've done Indian eyes in the United States, but when I've done Indian eyes in India, I actually think they do better. And my theory is that it's because, unlike in the US, where patients have their eyes abused by drops for 20 years, 15 years. In India, usually patients, at least the ones I've seen, have not been on drops for 20 years. They usually present in a more acute or advanced stage without having their eye been treated for so long. This is from one of my partners, one of my friends in Canada, talking about price per millimeter of mercury as far as MIGS is concerned, showing that GAT is without question probably one of the most cost-effective MIGS available. And thankfully, this is not a view of COVID. This is a view of how many around the world where I know GAT is being performed, and as far as I know, in over 24 countries. This is what I use. If you want to just do a screenshot for GAT, I'm not going to spend too much time on that. I have whenever the world opens back up again, we do teach a course. I direct a course at the American Academy of Ophthalmology, and I also have an open door policy. I'd be honored to come back and give a more extensive, longer talk on the nuances of the surgery. I think we've all been through so much. My heart has gone out to all my friends and family and colleagues in India. This is such a hard time for everybody, but I think it's so important for us to kind of just keep safe, stay positive, take care of yourselves and your family. Don't ever miss an opportunity to laugh and be a little silly. it's also time to be grateful and be thankful. And I'm so thankful for my friends and my colleagues and my family. And I take that time now almost on a daily basis to tell the people that are important to me who I'm thankful for. And I'm so thankful for the AIOS for inviting me, for the planning committee, for the president, Dr. Maipal, as well as all the members that were involved in planning this great conference. And I appreciate you all for giving me time to speak at 12:30. So please don't hesitate to call or to email me if you have any questions. This is my glaucoma family at home, and thank you all for your time.